Welcome to another installment of the Dutch webinar series. I'm Dr. Kelly Roof, a clinical educator here at Precision Analytical, makers of the Dutch test. In today's webinar, we're excited to welcome Dr. Tori Hudson, who will be delivering a webinar called Testosterone for Menopausal Women, Myths, Truths, and Benefits. We're glad you chose to join us to gain valuable insights into a more effective and integrative approach on this topic. Dr. Tori Hudson has been in practice for over 36 years and is the medical director of A Woman's Time in Portland, Oregon, program director of the Institute of Women's Health and Integrative Medicine, and director of research and education for Vitanica. She's a former academic dean and current adjunct professor at NUNM, Bastyr, Southwest College of Naturopathic Medicine, and the Canadian College of Naturopathic Medicine, and co-directs the Naturopathic Education and Research Consortium. If you're ready to start using Dutch testing in your practice, sign up as a registered provider today. Just click that link that we posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set up an account so you can begin taking advantage of all the education and resources that Dutch has to offer. Plus, registered providers gain access to our entire educational library, including courses like Introduction to HRT, Mastering Functional Hormone Testing, Perimenopause Management, and the Dutch Interpretive Guide, and also one-on-one consultations with Dutch clinical educators. This dedicated support and education is designed to help you become the hormone expert. If you have any questions as we go, please submit them, and we're going to do our best to address them in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It's a pleasure to have you with us today, Dr. Tori. Take it away.
Well, thank you, everybody, and thank you, Dr. Kelly. It's good to be with you all and with this fabulous team at Precision Analytical, aka Dutch Webinars, and they do such a great job of the technical support from my speaker's point of view and preparatory support, but also just the educational program they're offering is really quite stellar with so many things and so many people and so many topics. So I'm appreciate being part of that. And Dutch is also a sponsor of a nonprofit Naturopathic Education Research Consortium, which offers accredited residencies to naturopathic physicians. So I thank them for that. Okay, the topic of the day is testosterone therapy in women. And I do have a few disclosures, one of which is the Speakers Bureau, including Precision Analytical, but also on the scientific advisory boards of 3 different companies and director of education and research and co-owner for Vitanica. None of these things really matter today except for the Speakers Bureau for Precision Analytical. So let's get a little bit of a overview. But first, let's just say like testosterone therapy for women is a thing right now. Just like menopausal hormone therapy is a thing. We're kind of in this era of superfood thinking, which I kind of like us to pause at that notion. But there is certainly a role for testosterone therapy in menopausal women in particular. And it's just that we want to be careful how we prescribe it, when we prescribe it, who we prescribe it to. And that's the purpose of this lecture. So let's do a little overview. So testosterone acts directly as an androgen. That's how it's classified. And it also is sort of you might say, an obligatory precursor for the biosynthesis of estradiol. Since there is no feedback loop for governing its production that we know of in women anyway, it's not really that well understood. So we have some shortcomings here, like what really is a normal reference range for women? What are all the things that govern its production? We still have some gaps. It does exert physiological effects in reproductive and non-reproductive tissues in women. The concentrations of testosterone are associated with sexual function in women, but as we'll see, it's not really possible to make a correlation between a specific value or a specific dose and a grid-like expectation of response. But we'll talk more about that. The postmenopausal ovary is an androgen secreting organ, and the levels of testosterone are actually not directly influenced by the menopausal transition or the occurrence of menopause, but more about that later. It's important to know and to really appreciate this issue in particular is that serum testosterone levels in women are approximately one-tenth those in men, one-tenth to even smaller. And there is a small increase, maybe 20 to 30% at mid-cycle due to higher ovarian production. If a younger woman has her ovaries removed, like a premenopausal woman, and now she has her ovaries removed, there's an even greater reduction in testosterone levels than if she were to go through menopause and just have a postmenopausal ovary. So a postmenopausal ovary produces more than no ovaries. There approximately 66% of testosterone in women is bound to sex hormone binding globulin, also called SHBG, and it's a significantly larger proportion than in men. Increases in serum estrogen and thyroid hormone levels result in increased sex hormone binding globulin. So people who are taking thyroid medication, they're taking estrogen, especially oral estrogen. Again, we'll punctuate that a little bit later. Those increase SHBG, which means now we're binding up a little of the free testosterone, and that can matter in terms of her sexual function in particular. Again, more about that later. This slide just tells you what is the flow of hormone production, you might say. The only thing I don't like about this slide is that this is for menopausal women, and we still have mention of the testes there. But really, what I want you to appreciate about that slide is the number of hormones and androgens, preandrogens, cortisol, estrogens, and we'll pick this apart a little bit more. But look at the green there, DHEA and DHEA sulfate are related, go back and forth in terms of production. Estrogen goes back and forth with testosterone. Actually, testosterone makes estrogen, doesn't go back and forth. And so we need what we should see here that we need DHEA and we need testosterone and we need androstenedione to make estradiol. That is a very important concept. Well, what you might say, well, what about needing pregnenolone? You can see pregnenolone goes to kind of to the whole map. The reason why I don't use pregnenolone for the things that I would use estrogen for, or the things that I would use testosterone for, or even the things that I would use progesterone for, is because I don't, if I were to give pregnenolone, I don't really know where it's going, and nor does anyone. But I know some prescribers do use it, and they have their reasons and their logic. But for me, it's just it's too unpredictable about what it's going to synthesize into. Let's talk about production more. The ovaries, specifically the theca cells in the ovaries, produce a portion of circulating testosterone. The adrenal glands, located on top of the kidneys, also produce testosterone and its precursors, like DHEA, and we'll talk more about that. And then there are peripheral tissues where testosterone is produced, like skin and muscles, that convert androstenedione, another androgen, into testosterone. And then also in peripheral tissues, estrogen, which is there, can be converted to testosterone in adipose tissue. And then you might just go back and look at that flow, that map again. Let's look more at production. Quantitatively, women secrete greater amounts of androgen than of estrogen. That might be a little bit hard to wrap your mind around, but it's true. The major circulating steroids that are classified as androgens include the pre-androgens like DHEA sulfate and DHEA. It also includes the androgens testosterone and dihydrotestosterone. And it's only the testosterone and the dihydrotestosterone that actually bind to the androgen receptor. A little bit more about the pre-androgens. DHEA is primarily an adrenal product. It's regulated by adrenocorticotropic hormone called ACTH and acts as a precursor for that peripheral synthesis of the more potent androgens. DHEA is produced by the ovary and the adrenals and is also derived from circulating DHEA sulfate. And back to androstenedione and testosterone, these are both products of the ovary and the adrenal glands, and DHT is primarily a peripheral product of testosterone metabolism. These are sort of just these fundamental background things that are not all of which are not necessary to know or remember in prescribing testosterone, but it is important to know in terms of, oh, well, what does DHEA really do or not do? What does testosterone really do or not do? What does estrogen really do or not do? It builds on that sort of fundamental foundation. What about transport? Well, in women, testosterone is primarily transported in the bloodstream bound to proteins, and the majority is bound to that sex hormone binding globulin, but also to albumin. A small fraction, a really small fraction, exists as free testosterone, which is that biologically active form. And it's the free testosterone along with testosterone bound to albumin or bioavailable testosterone that's available for use by the body's tissues. A little more about transportation of testosterone. Again, the transport is largely mediated by proteins, the SHBG and the albumin. Those are the main proteins involved. The SHBG binds testosterone with very high affinity, meaning it holds on to that hormone really tightly. And in women in particular, a significant portion of testosterone is bound to the SHBG. The albumin, as I mentioned, binds testosterone, but with lower affinity, but it has a faster dissociation rate, which means it releases the testosterone from its protein binding more easily. And again, only a small percentage of testosterone is unbound and free in the bloodstream, and that's considered that biologically active form. That means it can enter cells and exert its effects accordingly. That term bioavailable testosterone means the amount of free testosterone and albumin testosterone. That's what makes up bioavailable testosterone. And then in women, testosterone can be converted to estradiol, the key estrogen, and it does that by an enzyme called aromatase. We said that and can confirm that testosterone levels are much lower in women than in men. There are exceptions. There are women that have much higher testosterone levels and still present as female. There are men that have much lower testosterone levels and present as male. But the usual scenario is women have much lower. While that is true, there's still some fluctuations, like I mentioned with ovulation. There's that little ovulatory surge, and there's a little bit of an uptick of testosterone. And maybe that's related to many women reporting increased libido at ovulation, which is handy in terms of fertility and ideal fertile times. With aging, in women, testosterone production declines, particularly after menopause, and that's because that decrease in ovarian function and adrenal function. I'll show you some graphs in a minute as well. Remember that DHT, that's primarily a peripheral product of testosterone metabolism. The testosterone is converted to the DHT by that enzyme 5 alpha reductase, different enzyme than the aromatase, and it does that in target tissues like the skin. And DHT is actually more potent of an androgen than is testosterone. And I mentioned again that testosterone can be converted to estradiol by the enzyme aromatase, also in the target tissue. Okay, what about excretion? So in women, testosterone is primarily excreted through the urine, both as unconjugated and unconjugated forms. A small portion of unchanged testosterone is also excreted in the urine, along with metabolites formed through hydroxylation and oxidation in the liver. And this is something that Precision Analytical tests as these urinary metabolites. And in some individuals, it does correlate with serum levels. There are also marked changes in ovarian and pituitary hormone secretion, but there are few changes in hormone metabolism. That tends to be fairly consistent. In other words, the metabolic clearance of testosterone and estradiol as well doesn't really change across the menopause. However, there's a shift in one pathway, that of androgen metabolism, and that's aromatization of the androstenedione and the testosterone in the peripheral tissues. So let's look at this graph here. A woman's ovaries primarily produce testosterone. I think I said this before, and I think I said you have to kind of wrap your mind around that. And it's that testosterone from which estrogen is made. Estrogen is made from testosterone, but not all the testosterone becomes estrogen. And there's enough that remains unconverted to estrogen to amount to about 1/4 of our daily production of this hormone. So this slide is about androgen production in the female. In women, about 40 to 50% of the testosterone is produced by the ovaries and the adrenals, 50 to 60% by peripheral conversion of the androgen precursors that I mentioned before: fat, liver, skin, brain. That's where it happens. And these tissues manufacture testosterone from the precursor hormones that are made in the ovaries and the adrenals. In other words, the ovaries and the adrenals are responsible for producing all the woman's testosterone, either directly or indirectly. And as long as women have fully functioning ovaries, our bodies produce, on the average, women's bodies, on average, 3/10 of 1 milligram of testosterone per day. Men produce 10 to 20 times as much, or an average of 7 milligrams per day. Most of the plasma testosterone is attached to SHBG, which I think I mentioned. Estrogen, I might have also mentioned, but I want to say this again because it is important when it comes to treatments. Estrogen actually stimulates the production of more SHBG, which then binds up still more testosterone, leaving there's less free testosterone to work on the cells and the tissues. And this is a problem when we give estrogen alone. If we have a peri or postmenopausal woman, let's stick with postmenopausal. It's clearer. Postmenopausal women, we have new hormone levels to deal with, which are essentially, we should say, low. And if we give her just estrogen and progesterone because she has a uterus, we could make her sex drive worse, particularly if we give oral estrogen. Now, I'm not completely dissing oral estrogen. I use it a lot, but oral estrogen increases that SHBG. So now we've essentially given her a hormone that can decrease the lesser amount of testosterone that is still left in her system. And so that's how libido can become worse. I see this especially in oophorectomized women who are on oral estrogen, and she had low libido to begin with because she has no ovaries, and now we're making it perhaps worse. So that is something to really keep in mind when it comes to treatments. Let's look at another concept of daily ovarian secretion of androgens. Regardless of a woman's age, her adrenal glands secrete primarily androgen precursors, and the younger woman's adrenal glands produce higher concentrations of androgens than postmenopausal women. Makes sense. During that climacteric and postmenopause, the ovarian secretion of androstenedione and DHEA decreases a lot. Look at that slide. We go from 1.5 down to 0.3. We go from 1 to 2 down to 0.1, 0 to 0.1. The testosterone secretion from the ovaries is the same, but the precursors are less, and that's why the overall amount is going to be less. And we'll say that in a different way. Here, we'll look at our serum levels. There's these changes that occur in the production and the circulatory levels of all three sex hormones during menopause. As those ovarian follicles become depleted, estrogen levels fall. Estrone falls by about 60%, estradiol by over 90%. Progesterone levels drop by 60%, and the decrease in testosterone is approximately 20%. What might be more important than testosterone is that significant decrease in androstenedione, DHEA, and DHEA sulfate. Look at that. They drop 68%, 72%, 81% for DHEA sulfate. That reduction in androgen levels is largely due to decreased androgen secretion by the ovaries. And this also results in fewer precursors available for conversion in the peripheral tissues, which further affects estrogen levels. So let's look at premenopausal, estradiol, postmenopausal, big drop, progesterone, big drop. Androgens, testosterone, not very much of a drop, but the drops of these pre-androgens is what really makes the difference in the total testosterone then available. And now you see this here, which is really the main chart to look at clinically is testosterone, premenopausal woman, postmenopausal, big drop if no ovaries. And I already mentioned the drop in DHEA sulfate, and the androgen. So the drops in these is largely how we get most of the drop in testosterone. And of course, women with no ovaries are really dinged when it comes to their androgens and their estrogens. Okay, let's change. So that's just sort of a background physiology, a little biochemistry in there. But now we get to therapy. This is where we need to be our strong suit and kind of up our game of knowledge. So there's something called the Global Position Statement, which was developed by consensus panel between big-time participating organizations around the world. And you see them there, the International Menopause Society, the European Menopause Society, the NAMS, which is the North American Menopause Society, now just called the Menopause Society, the Endocrine Society of Australia, International Society of Endocrinology. These are all major organizations with uber experts on menopause and on hormone therapy and including testosterone therapy. So they wanted to really inform healthcare providers of the known benefits and potential risk of testosterone therapy for women. And the task force of clinicians representing these leading societies, they came together, they looked at all the evidence, many discussions back and forth with the facts, and their goal was to provide really much clearer guidance as to which women might benefit from testosterone therapy. And also they wanted to identify symptoms, signs, and conditions for which evidence does not support the prescribing of testosterone, equally important, and then look at areas of uncertainty and look at the prescribing practices that have maybe the potential to cause harm. So let's go through their bullet points and their recommendations. And some of you might get a little squirmy, but we'll talk about the squirm a little bit too. So testosterone concentrations decline during reproductive years, but are maintained during menopause. They talk about how assays are very unreliable, and that's because women have this tiny, tiny amount. And so, how, can is the method used to measure adequate to detect these small amounts? What is a normal female reference range? That's a big question right there in premenopausal and in postmenopausal women. So really the main purpose of testing is to know if a woman has high concentrations, and therefore we would suspect some pathology depending on, how high, um, but also to rule out supraphysiological doses during treatment. So the main purpose of doing a testosterone test before prescribing is to be able to make sure we're not already high, therefore we shouldn't give more, or if during our treatment it becomes supraphysiologic, therefore we should reduce the dose, whether she's having side effects or not, by the way. They also assert that total serum testosterone is the main biomarker rather than free testosterone. And I sign off on that. And my colleagues who are menopause informed from reliable guideline sources would say the same thing, is that total serum testosterone is the main biomarker in the serum, not free testosterone, not saliva, not urine. That's not to say that those can't be used for some other scenarios, the metabolites and urine and assessment and saliva, but total serum testosterone is the main tool for assessing pathology and assessing dosing guidelines, you might say. Okay, terminology. Hypoactive sexual desire disorder and or dysfunction. Hopefully you've heard of that term. So HSDD and female sexual arousal disorder, FSAD are distinct conditions. They do have some overlap, HSDD and FSAD, but they do have distinct etiologies and risk factors and clinical features and responses to interventions, both psychological and biological. The diagnosis of HSDD, according to these global consensus guidelines, should be based on a thorough clinical assessment guided by available diagnostic criteria, such as that comes from the International Society for the Study of Women's Sexual Health. And so they have a model, which I'll mention again shortly, of how to diagnose HSDD. The association between endogenous androgen concentrations and sexual function in women remain uncertain due to issues relating to the sensitivity and specificity of the assay that I have mentioned, and just plain old insufficient data. In other words, if she has HSDD that we've determined by our assessment, she might have she could have a number anywhere on the reference range of the total serum testosterone. There's not a number result that associates with this degree of low libido, for example, or sexual dysfunction. There's not necessarily a number that we get to after our prescription that we should test to say, oh yes, now if we reach that number, your sexual function will improve. That is not the case. We're mostly using testing to rule out pathological elevations and to assure we don't overdose women. There's no cutoff blood level that can be used for any measured circulating androgen to differentiate women with and without sexual dysfunction. So we can't say, oh, here's the test, you have it. Here's the test, you don't have it. That's not what we use the test for. The task force found insufficient evidence to make any recommendations regarding the use of testosterone in premenopausal women for the treatment of sexual function or any other outcome. Some of you might find it hard to swallow that, but and I am one person, I occasionally prescribe testosterone to a reproductive age premenopausal woman, assuring that she doesn't have elevated testosterone to begin with. But if I can't find any other explanation of her HSDD on the best assessment that I know how to do, and we test her testosterone level, and especially if it's in the lower one third of total serum testosterone for her age, or especially if it's below, I'm going to think, I think she might benefit. I think she might improve. Her HSDD might improve. That's a subjective correlation. In contrast, there is high quality evidence that supports beneficial effects of testosterone replacement at physiological levels on sexual function in menopausal women with HSDD, whether it's surgically menopausal or normal menopause with ovaries. That's where the data is strong. That's where the data is supportive. Testosterone therapy in doses that approximate physiological testosterone concentrations for premenopausal women, there is a beneficial effect on sexual function, including increases in arousal, desire, orgasmic function, pleasure, and sexual responsiveness. And they just get less concerned, less anxious about sexual issues. These statements on this slide do not include pellets or injectables, but I would say there's no data on sublingual anyway. But any delivery that results in supraphysiological levels, whether it's any of the ones I mentioned, is undesirable. And we'll see shortly how they're not a fan of compounding. There is insufficient data evidence to support the use of testosterone to enhance cognitive performance. There's insufficient evidence to support the use of testosterone to delay cognitive decline in postmenopausal women. The available data at the moment don't show any effect of testosterone therapy on general well-being in postmenopausal women. It might improve well-being in premenopausal women, but the data is inconclusive. And there doesn't seem to be any data yet to show an effect on testosterone on depression. Now, might that you have a different response that you have observed and a patient of yours observed? Okay, so be it. That's great, but these are not indications for which we are guided to initiate testosterone therapy. The primary symptom is sexual dysfunction. There are few studies that have evaluated the musculoskeletal effects of testosterone. And you might be surprised to hear that. Of the studies that have reported musculoskeletal outcomes, the number of included participants has been very small. All participants were taking concurrent estrogen therapy. So that means we cannot say it was the testosterone. And no studies have been done in women with osteoporosis on testosterone only. The available data do not support an effective testosterone treatment on bone mineral density at the spine, total hip, or femoral neck, at least at 12 months duration of the study. No significant effects of testosterone administered in physiologic doses has been demonstrated on lean body mass, total body fat, or muscle strength. This is an area where I think we need clinical trials in postmenopausal women for body fat, muscle strength, lean body mass, bone density, fracture rates. We need that, and they admit that as well. What about some side effects? Yes, there are possible androgenic side effects from testosterone therapy, even if they're getting a physiologic dose. But that could be some acne, that could be some hirsutism. The acne goes away when they lower or stop the dose. Facial hair, body hair won't go away. It will then need to be managed. And these physiological doses, it doesn't seem to be associated with alopecia, clitoromegaly, or voice changes. But there's always the outlier. There's always like, why is this woman having significant androgenic side effects from a physiological dose and her total testosterone is not actually elevated? Now we might get to what's going on elsewhere. Do we know that we're not going to be testing for? I'm not going to be testing her receptor sites. So something else is going on that she's having significant adverse effects from very low doses and even low doses in the test results. Let's talk about oral testosterone. It is associated with adverse lipid profiles with negative effects on HDL and LDL cholesterol, and it is not recommended. It's not recommended for these reasons, but also oral testosterone just does not work as well as a testosterone cream or gel. Studies of non oral testosterone, like percutaneous and injectable, in doses that approximate physiological testosterone concentrations using premenopausal lab values, have shown no significant adverse effects on lipid profiles over the short term. So that's good news. Our preferred delivery, gel or cream, doesn't have a negative effect on lipids. Testosterone therapy has not been associated with increases in blood pressure, blood glucose, or A1 levels. There is a non significant trend for an increased risk of DVT seen in testosterone therapy. However, it's hard to sort out because the role of concurrent estrogen therapy in those studies could not be excluded. There's limited data that preclude assessment of the effects of testosterone therapy on heart attacks or death rates in women. Randomized controlled trials of testosterone therapy have excluded women at high cardiometabolic disease risk. So, what about those women? What do we know enough about those women? Most have included women taking concurrent estrogen therapy, and all have been pretty short duration. So, as a result, we can't really recommendations regarding the effect of these physiological doses of testosterone in postmenopausal women on cardiovascular health. It's not really fair to generalize to a more at-risk population or even generalize to long-term therapy. So we're a little bit in the dark in terms of cardiovascular stuff. Testosterone therapy does not seem to increase mammographic breast density in these physiological doses. Available data suggests that short term testosterone therapy does not impact breast cancer risk. You might ask the question, what do they mean by short term? I'm not precisely sure, but I think it's less than 4 years. Data from randomized controlled trials are insufficient to assess long term breast cancer risks. There's no data to support the use of testosterone therapy to prevent breast cancer. If she has a diagnosis of breast cancer, unfortunately, those women were excluded from randomized trials for HSDD, and currently, we should have an abundance of caution in recommending testosterone in women with hormone-sensitive cancers. Why? We don't know about the rates, the impact it has on recurrence, and remember, testosterone, much of it converts into estrogen, and we don't give systemic estrogen to breast cancer survivors who are hormone receptor positive. Therefore, it's advised to not give systemic testosterone. Female sexual dysfunction, including HSDD and FSAD and orgasmic disorder or dysfunction, have multiple etiologies. There's neuroendocrine glitches, there's physical health or disease issues, relationship, interpersonal difficulties, mental health, stress, maybe some sexually repressive cultural or religious or personal values. So, multiple etiologies is the take home there. Treatments should follow this biopsychosocial model and include pharmacologic options, hormone options, and other agents, psychotherapy, other multimodal treatments. It's important to become a skilled practitioner in asking these questions, not just questions about sexual function, sexuality, and their sex life, but their relationship that they're having with themselves or with others. You can have HSDD if you don't have a partner. We talk about that. Women who are dissatisfied with their libido, even though it's only self-satisfaction. It doesn't involve another person. So talking about these things, listening, empathizing, and asking questions about the relationship, of course, can be a very sensitive area. But we can do it. We can be sensitive. We can ask. The only evidence-based indication for the use of testosterone in women is for postmenopausal women who have been diagnosed with having HSDD after a good assessment. That is the only evidence-based indication. And then you have to decide if you're going to stray from that and why you're going to stray from that and be able to support that and think it through both with them, with the pharmacist, with the insurance company, with any other situation that might come. But let's don't be naive. It's not the primary indication. The evidence does not support well-being, mood, energy, musculoskeletal, heart for women. It supports HSDD. But there is an unmet need for the provision and approval of testosterone treatment specific to women. So in the United States, there's not an approved female testosterone preparation. It's not available. It's off label. In fact, it's the advice of this group, this consensus statement, is using 1/10 of the doses of male formulations. That is how to deliver the hormone testosterone and maintain physiological levels. So I have next to my slide, boo-hoo. This is their statement, compounded bioidentical testosterone therapy is not recommended for HSDD due to lack of evidence for efficacy or safety unless an authorized product equivalent preparation is not available. So in the US, it's not available. There is no testosterone preparation available to women unless it is a compounded product from a pharmacy. So even though we can be quite precise with the dose we want to deliver, they would prefer us to be, I think, less precise in telling the woman to just do a little 1/10 of this gel or this packet. I find that to be less precise, and I find that to be more tempting to patients to give themselves more than do 1 click or do zero point 0.1 mil from whatever dosing regimen you have with the compounding pharmacy. I think that is more precise and actually safer. And we have many more variable doses to give. We can give 1 milligram, 2, 5, up to 10 milligrams of bioidentical testosterone per day. We'll come back to that. Use of any testosterone preparation that results in supraphysiological concentrations of testosterone, no matter the delivery form, is not recommended. But it's especially not recommended with pellets and injections because those two methods of delivery just automatically deliver a high supraphysiological amount. Prior to testosterone prescribing for HSDD, a baseline total serum testosterone concentration should be measured before starting the treatment. Then you start the treatment after you get that number back and determine what you're going to do. It's best to repeat that test in 3 to 6 weeks. They come back in about 6 weeks after they've initiated treatment, and then we see how they're doing. Does it benefited them? Do they have any side effects? They should be monitored for their clinical response to the treatments and assessed for signs of androgen excess with the serum total testosterone level every 6 months. So we do it at the baseline, we give them the medicine, we have them do it again in, let's say, 6 months. The visit, what's their response? If the response is good and their level is not super physiologic, and then we'll have them come back in 6 months, and then we'll do it again. If there is no benefit by 6 months, then treatment should be discontinued. But let's say at that 6-week mark, I've given them 5 milligrams of testosterone cream per day. It's not I've done the follow-up test, it's not super physiologic, but also they have not had a response. They've not had improvement in their sexual dysfunction. I will likely increase the dose with a conversation with them, and then go at it again in another 6 weeks, test, respond with a visit, assess, etc. Systemic What about DHEA? Systemic DHEA is not associated with significant improvement in libido or sexual function. I would say that's what I generally see. Occasionally, I see someone responding to DHEA, especially if they had s- low in some uh, in some tests, but I'm prescribing it usually not for libido. But sometimes women just feel more comfortable starting with DHEA rather than testosterone, even though it's less likely to be effective. But as long as they have normal adrenal functions, it's not really recommended for HSDD. If there's no vulvovaginal atrophy, vaginal DHEA has not been tested and thus cannot be recommended for HSDD. There is vaginal DHEA for vaginal atrophy called genital urinary syndrome of menopause, or GSM. But if they don't have atrophy and discomfort, dryness, irritation, pain with penetration or touch, then that vaginal DHEA is not going to improve their libido. Here's a Cochrane review for postmenopausal women and libido. Their conclusion is that testosterone with standard menopause hormone therapy did improve sexual function. So there's good evidence that adding to hormone therapy has a beneficial effect on sexual function. The best effect seems to be concomitant use of estrogen and testosterone. But that's not all. We have studies on just testosterone. This is one of them. Surgically menopausal women, many were premenopausal and many were postmenopausal. The age group that they studied was 26 to 70-year-olds. They studied them because of HSDD and after they had their ovaries removed. They received concomitant estrogen therapy and either a placebo or the testosterone patch. The primary endpoint was the change in frequency of total satisfying sexual activity at 24 weeks. They had some secondary endpoints as well. And safety assessments. At 24 weeks, there was an increase from baseline in the frequency of total satisfying sexual activity of 2 episodes per month in the testosterone group, which was significantly greater than the 1 per month in the placebo group. The testosterone group also experienced statistically significant improvements in desire and a decrease in their distress. And the overall safety profile was similar in both groups. Let's look at another study in surgically menopausal women. 553 women with HSDD who had undergone previous hysterectomy and bilateral oophorectomy. The primary endpoint was change in activity and satisfaction and frequency of sexual activity. Results: total satisfying sexual activity significantly improved in the testosterone patch group compared to the placebo after 24 weeks. It was about twice as good as the placebo. Still, 1.5 episodes per month more versus less than 1 more per 4 weeks in the placebo group. The testosterone patch also significantly improved desire, decreased personal distress. Serum free total and bioavailable concentrations did increase from baseline. Overall, the adverse events were similar, which is good. Most of the androgenic effects, adverse effects, were mild. And then here we have a group of 814 women, 2 different doses of the patch, 150 microgram or 300 microgram. This is the patch that never came to market in the US. None were taking estrogen. So this is testosterone only. Both doses increased desire. So half maximum and maximum dose for women. But the most frequent adverse events was unwanted hair growth. 4 women in the treatment group were diagnosed with breast cancer compared with none in placebo. There was a slight but not statistically significant increase in invasive cancer at 3-year visit when testosterone was used with estrogen. Another group examined results of NHS and calculated the risk of breast cancer in women using estrogen plus testosterone to be 2.5 times greater than in women not using hormones. This is basically why testosterone did not come to the market in the United States, was this issue, which is the breast cancer risk. Here is a study, a small study, 36 menopausal women. They had just their uterus removed, but they did have HSDD. Women received an estradiol gel plus a 1% testosterone cream. Now, 1% testosterone cream is 10 milligrams per gram, which is the high end of the dosing for women wanting to maintain their femaleness, compared to placebo cream. And then they crossed over. At the end of 12 weeks, the active treatment group had increased testosterone by an average of 1.8 nanomoles per liter. No increase was seen in the placebo group. Testosterone cream significantly improved desire, frequency of sex, receptivity, and initiation. It did not change mood. It did not change energy, lipids, blood pressure, or weight. No side effects of the 3-month active group. What about vulvovaginal testosterone? This is something that I learned a long time ago. This is, you might say, kind of off label. A persistent leader in this topic, Susan Davis. The book that I originally read was The Hormone of Desire, but she's on many a published paper on testosterone in women. But the female arousal disorder or orgasmic disorder, anywhere from 1 to 10 milligrams per gram, 10 being the highest, but I generally start with like 4 milligrams per gram, apply a half a gram, so they're applying 2 milligrams on and around the clitoris before sex up to twice a week. So it's not a daily thing. We're using it for arousal orgasmic disorder. That's a compounded preparation. There was a trial of 80 healthy postmenopausal women. For 12 weeks, they used compounded vaginal cream containing testosterone, improved vaginal signs and symptoms. But in trials of vaginally administered testosterone in women with a history of breast cancer and taking aromatase inhibitors, they looked at 2 different trials. Serum testosterone levels were not fully characterized in 2 of them, but in the third, testosterone reached supraphysiological range, like 200 nanograms per deciliter after just 1 month, even though they were taking an aromatase inhibitor. And 12% had persistently elevated estradiol levels as well, meaning they were converting testosterone to estradiol. These are women with breast cancer on an aromatase inhibitor so that they don't try not to get a recurrence of their breast cancer, giving them daily testosterone, in this case vaginally, but it wouldn't matter. Uh, but the point being, daily is not a good thing in a woman with a history of breast cancer and a woman, even if she's on an aromatase inhibitor. You would think it would be less likely to be problematic, but it still is problematic. I mentioned adverse effects. The ones that I usually see are those 4: acne, less so hair thinning, but I do see that. Acne, increased body hair, and a testy feeling. Those things can happen even in physiological dosing ranges. The things that are like polycythemia, clitoromegaly, or voice changes, I have not seen those. And that's because I'm not giving supraphysiological doses. And if we do see adverse events, we should reduce the dose. If the adverse events don't diminish, then we should stop the therapy. Contraindications are similar to those with estrogen therapy. Do not initiate testosterone therapy in women, postmenopausal women with breast or uterine cancer, cardiovascular disease, or liver disease. I would say, though, if we are doing similar as we would with estrogen, we could conceivably give to an ER negative breast cancer patient. We can give to stage 1 endometrial cancers, but not stage 2 and above. Here are some compounded formulations. The maximum dose is 10 milligrams per gram, and they apply 1 gram a day to the skin. I don't usually start there. I usually start at least at half that dose. So, a sample economical way to go about this is you do the compounding pharmacy, 20 milligrams per gram, and apply 1/4 gram a day. So now we're delivering 5 milligrams, which is half that maximum. And you do to their inner arms, and you don't do the same dose over and over, I mean, the same location over and over and over. They move it around a little bit. You could do a gel instead, or you could do 1/10 of the tube or packet approved for men. As I said, I don't recommend that. I recommend, counter to the global consensus statement, of which I agree with pretty much everything else. My go-to prescription is compounded testosterone cream from a reputable and up-to-date with standards of consistent with the rules and regulations of the day. That's what the cream I think is a go-to. I should say I rarely use oral. I don't think I ever put it in a troche, and I never prescribe or recommend or refer for pellets or injectables because of dangers of supraphysiological levels. These are the testosterone products for men that you can use as a guide to figure out how to do the 1/10 dosing. The one product was taken off the market, the Androderm, but everything else is still available. And here are some more resources for you. Here are some resources from me. And of course, Precision Analytical and Dutch will have their resources and their team of fabulous clinicians and who are available to you for interpreting test results that you do with them. All right, I think we're done, and thank you so much, everybody, for your interest in helping more women more of the time. That's If we're doing women's healthcare, that's why we're doing it. All right.
Thank you for joining us for this insightful webinar with Dr. Tori. We hope you learned something useful. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about research behind the Dutch test at dutchtest.com/research. And make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. And be sure to follow at Dutch Test and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.